Burns. The priority concepts with this topic are tissue integrity, fluid and electrolyte balance, perfusion, and gas exchange. The interrelated concepts are nutrition, comfort, and mobility. Burns are a leading cause of unintentional death and injury worldwide. The extent of the burn injury is going to be related to the client's age, their general health status, the size and depth of the burn, and the specific body area that is injured. Burns can cause complications even after healing, such as contracture formation and scarring. Skin changes that result from burn injuries include anatomic changes. If the dermis is present with the burn, the skin can regrow. When the entire dermal layer is burned, all cells and dermal appendages are destroyed, and the skin can no longer regrow. And if the burn is deep enough, it can involve subcutaneous tissue, bone, tendon, and muscles. Functional changes of the skin. The normal functions include a protective barrier against injury and microbial invasion. It maintains normal body temperature. It activates vitamin D when it's exposed to the sun and helps maintain fluid and electrolyte balance, and also provides sensory perception such as pain, pressure, and touch. But burns can change the function of the skin, allowing for infection, hypothermia, and hypovolemia. And there are psychosocial changes with reduced self-concept. Burns are going to be classified by the severity, and that determines how much body surface is involved as well as the depth of the burn. Differences in skin thickness in various parts of the body are also a factor. We talk about superficial thickness, which involves the least amount of damage. The epidermis is the only part of the skin that's injured. We may see desquamation or peeling of dead skin about 2 to 3 days after the burn happens. These are usually pretty painful. Partial thickness involves the entire epidermis and the dermis in varying depths. Full thickness involves destruction of the entire epidermis and dermis. The skin will not regrow, and there's usually no pain with a full thickness burns because it also burns the nerves. As far as causes of burns, they can be chemical, electrical, from radiation, smoke-related, or thermal in nature. With chemical burns, the injury is going to be dependent on the duration of the contact with the substance, the concentration of the chemical, the amount of tissue that was exposed, and the chemical's action. Electrical will travel through the body. It has an entry and an exit wound, and has what we call an iceberg effect, as the external injury may appear to be very small, but the internal injury can be very significant. The injury will be dependent on the type of current, the pathway of the current, local tissue resistance, and the duration of the contact. Radiation burns occur with prolonged exposure to the sun or sources of radiation such as X-rays or the nuclear industry. Smoke-related injuries are more of the inhalation injury. We may see orofacial burns that can cause edema and impair breathing. So always assess the mouth, throat, and nose for soot. Thermal injuries can be from dry heat, such as contact with flame or explosions, And moist heat would be contact with hot liquids or steam. And contact would be from contact with hot metals, tar, or grease. This is the typical appearance of a superficial partial thickness burn injury. This is the typical appearance of a deep partial thickness burn injury. And this is going to be the appearance of a full thickness injury. And this is the appearance of a deep full thickness injury. And if you notice in the slide, there has been an incision made from the palm of the hand going down into the forearm. This is going to be a fasciotomy where they open the skin to allow for swelling. So as we recognize and analyze cues, we of course have to do our assessment. We look at the history. What is the source and cause of the injury, including are there any other potential injuries? What is the client's age, weight, and height, and what is their immunization history? Because one of the things that we will need to do with a lot of our burns is administer a tetanus vaccine if it has not been done within the last 5 years. We do the skin assessment. So we're looking at the size and the depth of injury and trying to determine the percentage of the total body surface area that is affected. We're looking at vascular changes. We're going to see a fluid shift with profound imbalance of fluid, electrolyte, acid-base balances. We can also see hyperkalemia and hyponatremia and hemoconcentration. Fluid remobilization usually will occur after about 24 hours. That diuretic stage will begin about 48 to 72 hours after the injury. And at that point, we begin to see hyponatremia and hypokalemia. With cardiac, we need to observe for hypovolemic shock, which is a common cause of death in the early phase in clients with serious injuries, and realize that vital signs can provide significant information as to the client's status. We should also look at the cardiac rhythm, especially in cases of electrical burn injuries, because arrhythmias can be common at this point. With pulmonary, we need to be assessing for facial edema. This can indicate inhalation injury, in addition to observing for coughing, abnormal respiratory sounds, dyspnea. We always suspect inhalation injury if the client is drooling, swallowing frequently. We see soot or singed facial hair, especially around the mouth or the nose. An inhalation injury can indicate a need for an artificial airway and potentially mechanical ventilation. Inhalation injuries can occur even when the lung tissues have not been damaged directly. Then we begin to see histamine and other inflammatory mediators causing capillaries to start leaking fluid into pulmonary tissue space, and this can lead to potential pulmonary edema. As for gastrointestinal changes, we have a decreased blood flow and sympathetic stimulation during the early phase that causes reduced gastrointestinal motility and can lead to a paralytic ileus. It can, however, also lead to what we call the Curling's ulcer in clients who have extensive burns, and we can also see GI bleeding. With the kidneys and urinary assessment, we do expect decreased urine output initially due to those fluid shifts. The expected output initially should be at least 20 mLs per hour. Metabolic changes that we will see include increased secretions of catecholamines, antidiuretic hormones, aldosterone, and cortisol. And we have an increased core body temperature as response to temperature regulation by the hypothalamus. Compensatory responses include that inflammatory compensation, which actually triggers healing. And the sympathetic nervous system compensation will occur when any physical or psychological stressors are present. Priority issues for clients with burn injuries in the resuscitation phase who have sustained a burn injury greater than 25% of the total body surface area include a potential for decreased oxygenation, a potential for shock, pain, acute and chronic, and potential for acute respiratory distress syndrome, or ARDS. The priority collaborative problems for clients with burn injuries greater than 25% of the total body surface area in the acute phase of recovery include wound care management, potential for infection, weight loss, decreased mobility, and decreased self-esteem. This is a picture of the rule of nines. This is a quick way to determine total body surface area. But notice that it includes the adult, the child, and the infant. And note the differences in the percentages of the different body areas. This is done in response to the proportional differences in the different age groups. And then we have the Parkland formula. This is how we determine the total fluid requirement in the 24-hour period. So, for example, we have a person weighing 90 kilograms with burns to 20% of his or her body surface area. They are going to, if you look at number 1, require 4 milliliters times that 90 kilograms and multiplied that by their total body surface area, which is 20%, they are going to require 6,000 milliliters of fluid replacement in a 24-hour period. We're going to give that first half, 3,000, in 8 hours, and then we give the remaining over the next 16 hours. They require a lot of fluid replacement. So, in addition, we have generating solutions and taking action. This picture is showing a picture of grafting. We have 3 phases of burn care: emergent, also known as resuscitation; acute, also known as healing; and rehabilitative, also known as restorative. In the emergent or resuscitation phase, this begins at the onset of the injury and continues for about 24 to 48 hours until diuresis occurs. Priorities in this phase include securing the airway, supporting circulation and perfusion, maintaining the client's body temperature, and keeping the client comfortable with analgesics and providing emotional support. In the acute or healing phase, this begins about 36 to 48 hours after the injury when the fluid shift resolves, and it will last until wound closure is complete. It is focused on the maintenance of the cardiovascular and respiratory systems, nutritional status, wound care, pain, and psychosocial interventions. The rehabilitation or restorative phase begins on admission, but the technical part of the phase begins with wound closure and then will end when the client returns to his or her highest possible level of functioning. The emphasis is on psychosocial adjustment, prevention of scars and contractures, and the resumption of pre-burn activity. This phase can last years or even a lifetime if the client needs to adjust to permanent limitations. One thing to remember, if we have chemical burns, one of the priority issues is decontamination. We have to remove the client's contaminated clothing and jewelry, brush any chemical powders off, and then copious irrigation with water. So in the acute phase, we need to maintain that airway, and remember this may require an artificial airway or mechanical ventilation or both. Oxygen. We also need to replace fluids. Those are your three priority interventions: airway, oxygen, fluid replacement. Fluid replacement will involve IV fluids. We have to get that I&O, and this will require an indwelling urinary catheter so we have accurate I&O. We need to remove the client's clothing and jewelry. Prevent infection. These clients with significant burns will be covered with a sterile blanket, and that blanket will be moistened with sterile saline. But we also need to prevent hypothermia. They will require analgesics, depending on the extent of the injury, maybe opioids or NSAIDs. With severe burns, these clients will be transferred to the burn center. They will also likely be receiving a tetanus vaccine. We can apply antimicrobial ointments or creams to the burns themselves, compression garments, and managing wound care, applying appropriate dressings. It may just be a standard wound dressing, but we do want the non-stick. We can do biologic dressings such as homograft, heterograft. The homograft is human skin. Heterograft is going to be skin from other species. Pig skin is one of the more common ones because it is very similar to human. Amniotic membrane, cultured skin, or artificial skin. We can do biosynthetic dressings or synthetic dressings. It may require mechanical debridement with hydrotherapy, enzymatic debridement with autolysis or collagenase, and surgical management. We may need to excise the burned tissue, and we may need to cover the skin with those skin grafts. This is a picture of a couple of surgical managements. The left side is the escharotomy, where we have that full thickness burn. Burned tissue loses its elasticity, so it will not expand. So we have to do the escharotomy to allow for swelling, allow for free movement of the body parts. And the fasciotomy in the left or on the right hand side is to allow for edema in the arm or wherever the burn is, so we do not have the compartment syndrome. So we have a client arriving to the emergency department with superficial facial burns from an explosion. The client has productive carbaceous sputum with labored respirations and singed facial hair. Based on these findings, what is the highest priority of care for this client? That priority concern is going to be the airway. An emergency assessment needs to be completed, but we have productive carbaceous sputum, labored breathing, and singed facial hair. These are all signs of inhalation exposure and smoke inhalation. And knowledge of the circumstances causing the burn is also very valuable in the management of the burn. But we have to do continuous airway assessment. It's a priority. This may require that artificial airway and or mechanical ventilation. Which symptoms does the nurse recognize that may indicate a pulmonary injury from the inhalation? Select all that apply. Development of a brassy cough, drooling, clear speech, audible wheeze, clear breath sounds. The correct answers: A, B, and D. 20 minutes later, assessment of the client reveals loud wheezing on exhalation. What is the nurse's best action at this time? Check the client's SaO2 with pulse oximetry. Apply oxygen and call the rapid response team. Call a code and bring the crash cart to the room. Call respiratory therapy for bronchodilator treatment. The correct answer is actually B. When we start having wheezing or crowing or stridor, that means the client's airway is being compromised. We have narrowed airways. They could be becoming obstructed. We need to get oxygen on the client and call rapid response. The client may need to be intubated. The nurse is caring for a client who is admitted to the emergency department with burns to the lower legs and hands. During the initial management, what is the priority nursing care? Assess and treat pain, evaluate airway and circulation, place 2 IV catheters and initiate fluid resuscitation, use the rule of nines to estimate the percent of body surface area burned. The correct answer is B. We always assess the airway and circulation first. It's been 12 hours since a client has been admitted for burns to the face and neck with associated inhalation injuries. The client had been wheezing audibly and the wheezing has now stopped. What nursing action is appropriate? Check the client's SaO2 level. Notify the provider immediately. Reassess breathing in 1 hour. Document improvement in the client's condition. The correct answer is B. Notify the provider immediately if the client with an inhalation injury becomes more breathless or audible wheezes disappear, because this can indicate a worsening of the client's respiratory injuries, including possible loss of the client's airway. And last question. A client has been receiving dressing changes with silver sulfadiazine for burn injuries over both lower arms. The nurse notes that the client's white blood cell count has dropped significantly over the past 4 days. How does the nurse interpret this finding? Electrolyte imbalance, infection is improving, impending kidney disease, possible allergic reaction to silver sulfadiazine. The correct answer is D. During therapy with silver sulfadiazine, a drop in the client's white blood cell count can indicate an allergic reaction. Silver sulfadiazine does not cause kidney disease, infection, or electrolyte imbalances.